This conference will now be recorded.
By serving the high-quality, genuine research work from eminent scientists, professors, scientific research communities in all fields of medicine, clinical, life science, engineering, and technology, to the research scholars, students, libraries, educational institutions, research centers, industries, with the aim of enhance your research in the respective fields. Our emphasis on offering state-of-art scientific information in formats most conducive to learning assures you of an optimal continuing education experience. Emerging technologies, massive paradigm shifts, regulation, governance, and new age of relative austerity mean that we must constantly evaluate our strategies to better serve the scientific community and to guarantee the value of your meetings. Recently, we have also started our own platform for open access peer-reviewed scholarly literature where all the content is freely available without charge to the readers. We aim to share the new recent advances through scientific publications, which will help in minimizing the borders and contributing the use of research works of eminent authors, scientists, researchers, research scholars, students, etc., across the broad spectrum of medical, clinical, pharma, and engineering scientific disciplines and subspecialties to promote the ideas which will guide the development and facilitate the use of scientific information and ensure its quality, and also will be connecting link between researchers and scientific community. We are committed to ensuring that our journals are disseminated worldwide so that researchers are able to access our content wherever and whenever they need it. Finally, we thank each and every one of you participants at this event, at this conference or webinar. We hope you'll enjoy the conference and your participation will contribute to new collaboration and research initiatives. So, yeah, for today's session, we can start uh, with Dr. Lyon Briggs from Griffith University, Australia. So, I guess Dr. Lyon Briggs is not available online right now. So we can just continue with our next session with Dr. Jenny from Royal Perth Hospital, Australia. If you are connected, yeah, before that, I would just like to explain you about the GoToMeetings. So yeah, just below the screen, you will have 4 options of mic, camera, screen, and leave. So while you're giving your presentations, you can just click on the screen button. So you will be able to share your screen and give your presentation. So it'll be helpful. And if you're having any queries, we are here to help you out in any point of time. So I would like to know if Dr. Jenny is available at the webinar online right now.
Yeah, hello. Yeah, we'd like to continue with the presentation of Dr. Hasan Seg Mirza, Baskent University, Turkey, and the title of the presentation is Antimicrobial Resistance in Neisseria gonorrhea, the need for new antimicrobials. Dr. Hasan, are you available online?
Yes, I am available online. I have recorded my video and have sent to Mrs. Sharon Charles. Is my video available for you, or can you show my video presentation, offline video presentation?
Can you please play it from your screen?
Okay, I will try it.
Okay.
Will I share you my screen and online present my presentation, or offline presentation?
Sure. You can just click on the button screen. So you'll be able to select which screen you would like to share to us.
Okay.
Yeah. Yeah, your screen is visible to us right now.
Sexually transmitted diseases, HIV/AIDS, and emerging viral diseases. My name is Dr. Hasan Cenk Mirza, and I'm a medical microbiologist and work as an assistant professor at Başkent University Faculty of Medicine, Department of Medical Microbiology. Today, I want to talk about rising antimicrobial resistance in Neisseria gonorrhoeae and the new antimicrobials currently in development for the treatment of Neisseria gonorrhoeae infections. Neisseria gonorrhoeae belongs to the genus Neisseria. The genus Neisseria consists of gram-negative cocci and consists of 28 species. But among them, only 2 species are pathogenic for humans. The first one is the subject of the Neisseria gonorrhoeae, also called as gonococcus, or plural form is gonococci, is the cause of sexually transmitted disease gonorrhea. And second pathogenic species in the Neisseria genus is the Neisseria meningitidis, also called as meningococcus, or plural form is meningococci. And it is a cause of meningitis and bacteremia in humans. Other species of Neisseria are generally harmless and inhabitants of the upper respiratory tract of humans, and especially they found in nasopharynx and oropharyngeal mucosal surface of humans. The humans are the only natural hosts of the sexually transmitted bacteria Neisseria gonorrhoeae. It is usually transmitted during sexual contact, but in rare circumstances, it can be transmitted from mother to her baby during the birth of baby. If a mother is infected, if she has an infection, progenital gonorrheal infection, baby can acquire the infection during the birth and acquire the infection from an infected birth canal of mother. The Neisseria gonorrhoeae attacks the mucous membrane of the genitourinary tract, eye, rectum, throat, and causes acute suppression in these sites, and after leads to fibrosis and scarring of these tissues. The most known, the most common form of disease is the gonorrhea. It is also called the genitourinary tract infections caused by Neisseria gonorrhoeae. But Neisseria gonorrhoeae also can cause disseminated infections, as septicemia and infection of skin and joints. But in rare circumstances, as I said before, it can cause ophthalmia neonatorum, which is the infection of the eye in newborns, and copulent conjunctivitis in newborns, and also it can cause pharyngitis. Gonorrhea is the second most common bacterial sexually transmitted infection in the world after chlamydia trachomatis infections. According to the estimation of World Health Organization in 2012, approximately 78 million new cases worldwide occurred, but in 2016, approximately 87 million new cases of gonorrhea occurred. So during a 4-year period, a rise of 10 million new cases is occurred. In men, the infection is primarily restricted to urethra, and the Neisseria gonorrhoeae generally causes urethritis in men. However, in women, in symptomatic women, it can cause generally cervicitis. But in a portion of 10 to 20% of women, it can cause pelvic inflammatory disease, also called SPID, and the most dangerous complications of these pelvic inflammatory diseases is the scarring of fallopian tubes and ectopic pregnancy and infertility. So this bacteria can cause infertility in both women and men. But we must keep in mind that the gonococcal infections may be also asymptomatic, especially in women. Unfortunately, previous attempts to develop a vaccine against gonorrhea were unsuccessful. So we must need antimicrobials to combat these global threats. In the slide, you see the timeline of gonorrhea antibiotic treatments and the dates at which when the first resistance to a specific antibiotic occurred. In 1945, penicillin first used to treat gonorrhea infections, and it has been successful. It has successfully used approximately 40 years, but during these years, the penicillin producing Neisseria gonorrhoeae and also tetracycline-resistant Neisseria gonorrhoeae occurred, and in 1987, the penicillin and tetracycline are no longer recommended for the Neisseria gonorrhoeae treatment. And in 1993, the fluoroquinolones were recommended for the treatment of gonorrhea due to high penicillinase producing Neisseria gonorrhoeae in the population. But in the upcoming years, the fluoroquinolone resistant Neisseria gonorrhoeae are occurred in the upcoming years, and in the year of 2004, fluoroquinolones are no longer recommended to treat gonorrhea by World Health Organization and Centers for Disease Prevention and Control. And at the same year, they recommend oral cephalosporins for the treatment of gonorrhea. But after 2004, the Neisseria gonorrhoeae isolates resistant to oral cephalosporins as well as ceftriaxone is reported from various regions of the world. So in 2012, the World Health Organization and Centers for Disease Prevention and Control revised treatment guidelines to use azithromycin and ceftriaxone combination therapy for the treatment of gonorrheal infections. And currently, the antimicrobial therapy by WHO guidelines for gonorrhea is the dual therapy, combination therapy, including azithromycin plus ceftriaxone. And the most European countries, also the USA, Canada, and Australia, follows this recommendation. However, some countries, as United Kingdom, Japan, and China, still uses and recommends ceftriaxone high-dose monotherapy for gonorrheal infections. However, although this recommendation, the first failure of ceftriaxone and azithromycin dual therapy is reported in 2016 from United Kingdom, and after 2 years, in 2018, the first Neisseria gonorrhoeae strains with resistance to ceftriaxone combined with high-level resistance to azithromycin is reported from the United Kingdom in February 2018. And after a few months, a similar strain, a resistant strain, is also reported from Australia in April 2018. So after these reports, the Neisseria gonorrhoeae is included the World Health Organization priority pathogen list for research and development of new antibiotics. So you see the Neisseria gonorrhoeae in these lists with other important pathogens. So, new antimicrobial agents are needed for treatment of gonorrhea because the Neisseria gonorrhea developed resistance to all previously used antimicrobials. So, the promising antimicrobials, new antimicrobials that are currently in development for the treatment of gonorrheal infections include gabapentocin, lefamulin, and zoliflodacin. Gabapentocin is a novel antimicrobial in the class of antibiotics known as triacenaphthalanes, and it has a broad inhibitory activity against both gram-positive and gram-negative bacteria. Its mechanism of action is to bind to DNA-gyrase and topoisomerase 4, and after that, it inhibits the bacterial DNA replication and kills the bacteria. Its mechanism of action resembles to those of quinolones, but the binding site of gabapentocin is distinct from that of quinolones. And you see the chemical structure of gabapentocin in the slide. In a phase 2 study, the microbiological curve was achieved in 96% of patients with urogenital infections with gabapentocin treatment. And the authors of the study concluded that a single oral dose of gabapentocin were highly effective for bacterial eradication of Neisseria gonorrhea in adult participants with uncomplicated urogenital gonorrhea. And also the adverse events of the gabapentocin are mainly gastrointestinal symptoms and were not treatment limited. And a phase 3 clinical trial has commenced in October 2019. A study evaluating efficacy and safety of gabapentocin compared with ceftriaxone plus azithromycin combination therapy in the treatment of uncomplicated urogenital gonorrhea was commenced, and the estimated study completion date is April 2021. The second new antimicrobial that can be used to treat gonorrheal infections seems to be lefamulin. It's a novel semi-synthetic fluoromotilin antibiotic, and uses the chemical structure of lefamulin in the slide. It inhibits the bacterial protein synthesis by binding to the 50S ribosomal subunit, but its binding sites are different from other antibiotic classes as macrolides. Actually, this antibiotic is approved in 2019 by FDA to treat acquired bacterial pneumonia, and also it has completed a phase 2 clinical randomized control trial for bacterial skin and skin structure infections. In an in vitro study, the in vitro study included 251 isolates of Neisseria gonorrhea, including drug-resistant and extensively drug-resistant strains. And in this study, in vitro study, lefamulin showed potent activity against all of the isolates, and no significant cross-resistance to other antimicrobials was identified in the study. However, in vitro studies are not enough, and also additional pharmacodynamic and pharmacokinetic studies, especially for the sites that Neisseria gonorrhea involve, such as the human urogenital, pharyngeal, and rectal mucosa, are needed to assess lefamulin as a treatment option for gonorrhea. So, another agent, the currently developed for the treatment of uncomplicated gonorrhea is the zoliflodacin. It's a member of a nucleus of antibiotics known as propionic enantiomers, and the zoliflodacin has activity against bacterial type 2 topoisomerases and inhibits DNA biosynthesis and causes the death of bacteria. Despite targeting the same proteins with fluoroquinolone antibiotics, mechanism of action appears to be different because a little cross resistance with fluoroquinones are demonstrated. In a phase 2 study, a single oral dose of zoliflodacin, 2 or 3 grams of single dose of zoliflodacin therapy is compared to a single dose of intramuscular ceftriaxone. The study included 179 participants with gonococcal infections, but 141 of these participants had gonococcal infections. The remaining of the participants had pharyngeal or rectal infections of Neisseria gonorrhoeae. In urogenital infections, in participants with urogenital infection, the microbiological cure rates were higher than 95%, both for zoliflodacin and ceftriaxone. However, in the same study, ceftriaxone was found to be superior for treatment of pharyngeal gonorrhea. The adverse events related to zoliflodacin were mostly gastrointestinal symptoms, and these are generally self-limiting. This is the good news. And after that, a phase 3 clinical trial was commenced in September of 2019 for zoliflodacin as compared to a combination therapy of ceftriaxone plus azithromycin in treatment of uncomplicated gonorrhea. And the estimated study complication date of study is August 2021. So, as a conclusion, novel antibiotics to be developed for gonorrhea should have high efficacy in multiple tissues, preferably in a single oral dose, and preferably be inexpensive for economically disadvantaged populations. And the new antimicrobials that fill these criteria can expand the repertoire of antigonococcal therapies and have the potential to delay the development of resistance to other antibiotics. I would like to thank you for your attention and interests, and thank you for your listening.
So, yeah, as we know, yeah. So thank you for your presentation, Dr. Hassan. So now, do we have any like doubts or any questions for Dr. Hassan so that he'll be able to answer your questions? If anyone have any query, you can please ask Dr. Hassan.
Yes, I can answer your questions if any.
I'm presenting today on a new explanation of.
So yeah, so now we can carry on with our next presentation. So Dr. Jenny has sent us a video presentation through email, so I guess is not available right now. She's not available right now, so we'll be playing her video. So yeah, you can just take a look on about it. So the topic is syndemic synergy of HPV and other sexually transmitted pathogens in the development of high-grade anal squamous intraepithelial lesions. So yeah, here we can start the presentation.
Rising rates of anal cancer. STD. I'm presenting today on a new explanation of rising rates of anal cancer, STD interaction. And I'd like to acknowledge my co-investigators in this work, and I've also invited the statistician and epidemiologist Michael work as well, because it's a very interesting study. So it started off by me being interested in anal cancer. I did a PhD on this, and what we're aware of is that worldwide there are rising rates of anal cancer, and you can see in the slide presentation, on the slide on the left, that the yellow is females. The rates of anal cancer are rising faster in women than men, and we also know that anal precancer and in association with high-risk HPV is a precursor to anal cancer. We also know another not well recognised fact that anal warts are also associated with the development of anal cancer, and particularly in HIV infection, where we see really high rates of anal intraepithelial neoplasia. But the basis for this particular piece of research that we're presenting to you today is there are cofactors other than HPV that are thought to be associated with anal cancer and its precursors. So there's many cofactors associated with the development of anal cancer. So in particular, the commonly recognised ones are receptive anal sex, sex before the age of 30, the number of sexual partners that an individual has had being female, current cigarette smoking, immune suppression with organ transplantation, HIV infection, and anal fistula and epithelial trauma. And as I said, with genital warts, people think that warts are benign, but I'll present you some research shortly that shows there's a lot of high-grade epithelial neoplasia in warts, and individuals with genital warts have significantly increased risk of anal cancer, but also other cancers such as head and neck cancers. And it's well described in the literature. There are many case reports where anal cancer has been seen to arise out of a bed of anal warts. And there's also been some interesting research presented by the Danish group where they found that in women with genital warts there is persistence of high-risk HPV. The basis that we use for this research is a surgical database that we established at Royal Health Hospital. And that's now been established as a tissue biobank, and we're shortly to release that on a website, so that is available for people who are interested in doing further research. But we established this surgical database in 1996 for all patients who attended a sexual health service and they had surgical removal of warts in theatre. And you can see in the pictures there the sort of warts that were being removed. So those are large field warts within the anal canal and extensive perianal lesions, but some of the patients didn't have such significant size lesions. And we collected data on patients prospectively prior to the time of surgery and at the time of surgery. And we previously reported that there is a lot of high-grade intraepithelial neoplasia, 52% in men with HIV. This is in the warts. And if you have anal or perianal warts and you're heterosexual, then 20% of those men have high-grade intraepithelial neoplasia. And the rates of intraepithelial neoplasia in the HIV positive individuals were at least double that of the HIV negative individuals. So in this series of patients with warts who underwent surgery from December of 1995 to November of 2016, there were 463 individuals, and about a quarter of those had a second or third operation. So the total number of operations in this group was higher, being 536. And we collected on these individuals their sex, their sexual preference, the number of lifetime partners, and whether they'd ever had a history of gonorrhea or chlamydia. And we always checked in the notes to see if there was clinical evidence of the actual infections. And being in a sexual health service, we were able to substantiate a significant proportion of those, even though it was a historic, just a question asked on history. And when they were enrolled for surgery, or prior to the time of surgery, we also did the following blood tests. So we did syphilis serology, herpes type 2 serology, hepatitis A, B, and C, and HIV 1 and 2. And then from June 2005 on, at the time of surgery, we also did anal high-risk HPV testing. And for the purpose of this study, it was the diagene hyperfactor 2 test that we actually did. Now, in surgery, all the material that was excised was actually sent for histopathology. So there were no random biopsies or just bits of tissue. All the material has actually been sent for examination. And as I say, that was also being stored in our biobank. So of the 314 individuals who actually not only had warts but had high-risk HPV testing, there were 261 men and 53 women. And the majority of men were HPV positive compared to only 40% of the women. 80% of the men who had sex with men were HPV positive compared with only 47% of heterosexual men. And 40% of the men were HIV positive, and HIV was strongly associated with HPV infection. And we found that HPV positivity was associated with a 6.5 times increased risk of having a high-grade squamous intraepithelial lesion. So we mentioned that we analyse this work in a syndemic manner, and what is syndemic? So we looked up Wikipedia, and the definition in Wikipedia is that it's a synergistic epidemic, which is the aggregation of two or more concurrent sequential epidemics or disease clusters within a population with biological interactions which exacerbate the prognosis and burden of disease. And I certainly have to compliment my co-researcher Michael Phillips here, which has given us some extraordinary and, to me, extremely concerning insights in what the future holds for the rate of development of anal carcinoma. So the syndemic approach, where we're really looking at one epidemic or multiple epidemics affecting another epidemic, is different to the other type of research, which has classically been where we diagnostically isolate, study and treat diseases as distinct entities. This type of research tells us an idea of what is more likely happening in the real world. And so I'd like to now hand on to my co-researcher, Michael, to explain the data and a bit more about the type of analysis that was actually performed. Thank you, Michael.
Today, I'd like just to start my contribution statistical approach that we took to examining the syndemic that Jenny's already alluded to. And it's quite a complex approach. It involves a thing called a structural equation model, which is a series of simultaneous equations. You remember high school mathematics. And those equations are interrelated, so that we have a multivariable analysis, which many of you will be familiar with, a primary dichotomous outcome, which is the presence of neoplasia. And so it's fundamentally based or similar to logistic regression analysis. But the difference is that we can do things with structural equation models that we can't do with standard regression analysis. And one of those is that we can incorporate path analysis. And what path analysis allows us to do is to detect the most likely progression through a series of variables, much like a map comes to do path analysis. The other thing we can incorporate is something called a latent variable. And a latent variable is something which is not observed, but is inferred from a series of inverse, a series of observed variables. It does perhaps sound very complex, but one of the beautiful things about structural equation models is that it gives you pictures. And we can incorporate into the pictures the independent variables, which Jenny's already described, which is STDs, as well as covariates like age, gender, sexual behavior, and number of sexual partners. And in the slides, there's a very
I forgot my headphones. Hello, sorry, it's Dr. Ivana Balter from France joining. Is it possible to make it louder, because it's very difficult to hear?
Sure. Just a moment. So, do you want me to?
Yeah. Just I hear it perfectly now. Yeah, thank you. And is it possible to send the comments on the chat?
Yeah, one moment. So,
So
one
thank you
second.
for resending. Yeah, thank you for resending me. It's working now, the connection.
Okay, so it's
So hello.
working. Okay.
So hello everyone. So again, Dr. Ivana Balter-Halushkova from France, but currently in Lebanon, in Beirut. So please think about this country, which is just amazing, and going through the struggle. So everyone who is listening, I'm meantime asking anyone who can help or to be useful to be with us. But let's go to the scope of the meeting, and if I can have an option of chat, because I have few comments on the topic.
Oh, actually, we are in middle of a presentation, Dr. Ivana. So will it be able, we'll just have
Some
your.
chat that can be answered later. It doesn't matter. Okay.
Okay. Thank you. So, yeah, I'll be continuing with this presentation right now. So, yeah, in just maybe in 10 minutes, we can have your presentation, Dr. Ivana.
Okay. I will try. I will try. It said the connection. I will try my best. Okay.
Okay,
Yeah, but
okay, no problem.
did you receive it? Because I sent it yesterday. Did you receive it? Yes or no?
No, we haven't received.
Uh, okay. So anyway, I will speak. I will speak from my mind. It's in my head. I'm sorry. Okay. So
Okay.
I will put the mute and follow for now the presentation.
Yeah, we'll just have your presentation in just 10 minutes. Yeah. So, yeah, we're sorry for the inconvenience, and yeah, we'll be continuing with this presentation of Dr. Jenny.
The primary outcome is H,
Mm.
and person on the right hand side, it's all of the arrows eventually go to H cell. So this is the outcome variable. And we've got two latent variables that we've constructed from the data. One is cofactors, age, gender, whether or not the person is heterosexual, and the number of sexual partners. The other latent variable describes the collective of other sexually transmitted diseases. So you can see HIV, HSV2, syphilis, gonorrhea, etc., as described by Jenny. And you can see also that the arrows that connect the elements of the structural equation model show odds ratios, and the p-value associated with those odds ratios. You can see an awful lot of p-values below 0.05, and the collective p-value is less than 1,000. So that allows us to be able to describe how these patients have arrived at H sort of endpoint. We've got predominantly men. The middle age, or the median age, is 42 years. 80% of the men who have sex with men. 38% of men and 6% of women have more than 50 sexual partners. HPV, high-risk HPV positivity is high, 75% for men and 40% for women, and multiple sexually transmitted diseases were also evident. When we look at the breakdown of the association between HSOR and HPV positivity, it's of course enormously strongly associated. 6.5 odds ratio. And we are relatively confident that this really does establish that high-risk HPV is a necessary cause of this disease. But it's not the only cause of the disease, and we found three groupings of STIs that also contribute to the problem. There's HPV, HIV, HSV2, and hepatitis B. They form one component. syphilis and hepatitis C form another component, and gonorrhea and chlamydia a third component. When we look at high-risk HPV positivity plus or without HIV, then we see very strong associations. And Jenny's already described those in those shown in the slide. The strongest of those associations, of course, between HIV and HPV, but magnified in the presence of HSV2, syphilis, gonorrhea, and chlamydia in particular. And our findings, we believe, reinforce findings that other people have shown in their other research. Thank you.
So, Michael, thank you for explaining that extraordinary findings. I was, to be involved with collecting the surgical material and then doing a PhD to find these findings is extraordinary. And as I said, I'm really quite concerned about what I see happening in the community. But let's try and look at some biological plausibility as to why some of the STIs and all of the ones that we've studied, so we've mentioned HIV, gonorrhea, chlamydia, herpes, and some of the serology has amplified the risk of high-grade intraepithelial neoplasia, and therefore we think the future risk of anal cancer. So how might this actually be working? So we think that at a local level, that gonorrhea, by its production of acute inflammation, is possibly one of the mechanisms that might be driving the development of intraepithelial neoplasia. Chlamydia has been, the Danish people have demonstrated chlamydia increases the risk of high-risk HPV. This has also been previously shown in prostitutes in Nairobi. That's published data. So again, chlamydia in the anal canal, then the inflammation from that may also lead to persistence of high-risk HPV and therefore be a driver for intraepithelial neoplasia. Genital herpes, or herpes type 2, was thought many years ago to be a cause of anal cancer, but as soon as we discovered high-risk HPV, then genital herpes went out the door. But we know that herpes is a known mutagen, and I think that it may very well have a very important role in the uptake of HPV and the development of serious precancer precursors in individuals. Syphilis has other evidence for cancer association, and we believe there's a systemic reaction that gives precedence to the development of intraepithelial neoplasia with HIV, hepatitis B, and hepatitis C. And to put this into the local context, because this is data that we've established and inferred from our biobank, but I want to show you that, and this is actually happening in many cities worldwide. So the snapshot and understanding of local data can be expanded. But our rates of chlamydia by sex from 2007 to 2016 have shown that the chlamydia rates are increasing, and there's just been, again, more data recently published here that shows that the rates are continuing to escalate locally. The gonorrhea, again, is a significant problem locally where gonorrhea rates are going up, and the data of the last few years again show that these rates have gone up even higher than what I'm showing you now. And infectious syphilis, again, is we've just now, the health department has called a meeting of clinicians in Perth and other people because there's an infectious disease epidemic currently. So again, the syphilis has skyrocketed over the last few years. So to put that into context, what I'm saying is we have high-risk HPV and anal warts in the anal canal, and that we think that not only is high-risk HPV important, but these other infections which are arising in epidemic proportions are likely playing a very, very significant contribution to a future epidemic of anal cancer. What I haven't mentioned on this slide is that now there are many men who are taking antiviral medication to avoid catching HIV. They're not using condoms. And so the rates of STIs are increasing, and I believe this group of individuals now is of particular risk for a huge escalation in anal cancer development in the future. So just to recap, that the development of intraepithelial neoplasia in the anal canal shows syndemic interactions with STIs and behavioural and social factors. The STIs, especially gonorrhea, syphilis, chlamydia, and genital herpes, are linked to the development of intraepithelial neoplasia high grade, and that we'd like to see other researchers study this further. And given the rates of gonorrhea are so high now in men who have sex with men, it's really important that they be counselled to avoid STI acquisition and to use condoms. And as I say, with the use of PrEP, it's condoms off. My message is that we really need to encourage the condoms on. And then again, where the detection of high-grade intraepithelial neoplasia is problematic because there's scarce resources. We're lucky here in Perth that we run a high-resolution anoscopy clinic, and it could be that herpes type 2, if further research is done, may be used to triage patients into the clinic, as well as anal cytology and high-risk HPV screening. So I'd like to end there, and thank you very much for being able to present today, and thank you, Michael, for co-presenting with me today.
So yeah, that's the end of the presentation. And yeah, so here we have Dr. So I would like to know if Dr. Deepak do not have any problem in for the next presentation to be given to Dr. Ivana.
Yes, can you hear me?
Yeah, no problem.
Yes.
You can continue.
Yeah.
Thank you.
Yeah,
Thank you.
I apologize. This is a total improvisation because I am by unpredictable events in Beirut now in Lebanon. So please just confirm that you can hear me. You might not
Yes.
see me the same time because the connectivity, I'm trying my best.
Yeah, we can hear you.
So yeah, so thank you very much. I was very carefully listening the previous presentation, and from my side, I would be more than happy to take it from the other side, because just to briefly to introduce myself, I am a physician trained in infectious diseases and tropical diseases in vaccine and in immunology, and I'm a part of the Academia of French Immunology Society. And I am doing a partnership between the science translated for health. So my topic was more orientated when speaking about the sexually transmitted diseases, and in the nice presentation, I was looking carefully to take occasional to make us think about other parts where the host system, immune system, I was trying to send a slide, but it didn't pass through. So what I'm going to do is to share via WhatsApp my written presentation. It's improvisation. I apologize because I'm not in Paris. So host immune response co-evaluate with the pathogen and commensal microbiota given individual genetic predisposition. Can you hear me? Please say if you don't, because it's sometimes getting interrupted. Can
No,
you
we
hear
can
me?
hear you clear. We can hear you clearly.
Thank you. So there is a genetic individual predisposition variability and remains along with the neuroendocrine system one of the key to maintain homeostasis of organism in general. But the human gut, and I mean this is very closely linked also to vaginal microbiome system, nasal microsystem, and the skin microbiome harbor a complex microbial ecosystem which consists of hundreds of species, collectively termed like gut microbiota. The gut microbiota is influencing very much, and there are long research, and I said I will try to follow with the slides once back in Paris, in stable and healthy adults, but the composition of gut microbiota can change rapidly owing to dietary changes, illness, stress, immune diseases, use of antibiotics, chronic diseases. Importantly, there is evidence of existing communication between the central and enteric nervous system, signaling from gut microbiota to brain and from brain to gut microbiota by means of neural, endocrine, immune, and other paths. I would like, in my presentation, which I'm sorry that my slides didn't pass, to highlight that there is recent research which is confirming a growing evidence between disruption of gut microbiota for many reasons, for use of antibiotics, cesarean section, and bad nutrition in HIV-infected immune recovery and response, and the composition of vaginal microbiota and the susceptibility to HIV infection, and in addition, also to responsiveness when we were talking and I was looking at the slides, also to vaccine, as a HPV vaccine. However, laboratory studies such ex vivo or animal experiments are needed to move from plausible mechanism towards proven mechanism that explain the effect of vaginal microbiota on susceptibility to sexual transmitted diseases. Further evaluation confirming that the sustaining optimal microbiota reduce risk of a sexual transmitted infection, including HIV, including gonorrhea, including the list which was previously in a very, very nicely summarized presentation I was following. I try to focus on HIV. It's a chronic inflammatory diseases in which numerous structural enterocyte apoptosis, sorry for technology terms, and the loss of epithelial integrity, functional mean errors in the production of mucin and the EGL, immunoglobulin A locally, and the immunological loss of submucosal lymphocyte defects contribute to access and the risk to acquire or progress on the diseases. I'm just asking, can you still hear me clearly?
Yes, yes,
Hello?
yes, we hear clearly.
Yes? Yes?
Yeah, yes.
Do you want me to speak louder? Do you want me to speak louder? It's still okay?
We can hear you.
So what I was, thank you. So what I was trying to say, that taking an example from HIV, but this concern also gonorrhea. We know gonorrhea is going to be one of the. I'm taking care about the antimicrobial resistance, and gonorrhea is one of the top of the list of the resistant pathogens when the treatment is failing. So my objective on the presentation, if I summarize it on slides, unfortunately you didn't get, is to work on enhancement of human microbiota and the human immune capacity. Because, as I was mentioning before, the laboratory studies as ex vivo or animal experiments are still missing and needed despite of the huge research preclinical test. And there is a very strong mechanism toward proven explanation that there is an effect of link between a marginal microbiota immune response and a susceptibility to a sexual transmitted infection. So the HIV virus is a chronic inflammatory disease, and as I was saying, numbers of structural like enterocyte apoptosis, the loss of epithelial integrity, and this is, as a barrier, similarly as a skin barrier, similarly as a gut barrier, similarly as a nasal barrier, which exposes to external pathogen. Then there are functional errors in the production of mucin, immunoglobulins locally, and other immunological, let's say, factors like loss of the mucosal lymphocytes who are signaling to adaptive and then innate system to respond correctly. So based on the recent research, one must note that the changes in a gut ecosystem in HIV, I took this because I didn't want to go through all STD diseases, but it's very relevant for all. Undergoing traditional antiretroviral therapy, which is resistant soon or later, might be both as a consequence and potential cause of the recovery of mucosal and systemic immunity. So active gut bacteria are involved in controlling mucosal epithelial integrity and the accumulation of pro-inflammatory mediators and molecules that reduce viral infection and increase immune recovery, and plasma metabolome analysis demonstrated, there are preclinical research that I can follow up with you, that the human response reciprocally by increasing the biosynthesis of anti-inflammatory and pro-solving lipid mediators that circulate in the bloodstream. Altogether, it's plausible that the host immune system and synergism with the bacteria mediates the solution to inflammation and promotes or not immune recovery. Gut-active bacteria and a molecular agent may not be only one contributing to immune recovery in HIV patients, and I took it as a list of STD examples, but they certainly may play a key role in HIV progression and chronic immune response, and thus life expectancy in HIV patient during effective treatment, ART, which is we know becoming resistant, and we are looking for a new solution. Further studies to evaluate the impact of treatment, antiretroviral treatment. I take example again, HIV. On the gut microbiota, it's another topic. Prior and during treatment, along with studying HIV uninfected patients and analyze the effects following HIV infection are really needed. I say it's a lot about the interaction between the gut innate system training to respond better to treatment, to respond to infections. You might get infected, but you will not develop the illness. And finally, as previously noted, existing and growing data suggest the need to assess the metabolic contribution of gut bacteria to recovery or to maintenance of persistence of defects in innate and adaptive immunity across various infectious diseases, including HIV. But as said, and it's not necessary to list gonorrhea and etc. because gonorrhea, it's said, one of the top lists of pathogens where the treatment is failing. Modeling microbiota and the host immune response capacities, along with the research on innate cell immunity, expect to bring new view on infectious sexually transmitted diseases, and I am very convinced, and I will follow or share some few references on a presentation I'm improvising from middle of Beirut. So I apologize. Did you hear me clearly?
Yeah, we could hear you clearly.
So I will send you what I was talking about, and when I will be back in Paris, I will try to follow with the slides. But the key message is, don't look only in various treatment, because as said, the HIV treatment, there are still new treatment and new combination, and sooner or later it's failing. But the key message is to look on the host immune system, and there is a very strong scientific evidence from preclinical data that the training of the immune cell through the gut has very close link on the sexual transmitted diseases and the capacity to might get infected, but to not have a progression of diseases. And the third point, because I am involved in a group around the antibiotic resistance, gonorrhea, it's one of the pathogen which is highly resistant to treatment. And the fourth point, and this is something I think, given the group and the numbers I see, the prevention, it's a case. So early detection of and education, it's also part of the story to explain also this part of first immunity, prevention, protection, but very close link about the role of nutrition and metabolism and immunity against sexual transmitted diseases. And I will, as said, as back in Paris, I will send you the presentation in a short few PowerPoints. For now, it will be just a word text because it didn't pass. Okay? Very happy to participate because STD are one of the major public health, and spending some time in India and Africa, I know that there is a missing a basic protection, but there is a lack of education, there is a resistance to treatment, and as said, it's increasing evidence that about the role of the immune system training through the gut on the vaginal colonization and resistance to all bacterial or viral pathogens. So thank you for your attention. If there are any question or or whatever, please send it through email that you have or WhatsApp, and I will try to answer my best. In the meantime, I will send my contribution, what I was talking about, and few slides when I will be back in Paris. So again, apology, but I'm in a really in an emergency city where the things are quite serious.
Yeah, we completely understand, and thank you for your presentation, Dr. Ivana. So once we'll receive the presentation from the PowerPoint presentation from Dr. Ivana, and we'll definitely circulate it among all our attendees today. So if you're having,
At
and we'll
least a
also,
Word document, so you
yeah,
have some key ideas. So I will try to send this, and then once I am back in Paris, I will compile the PowerPoint presentation I wanted to do, but few days ago I had no idea that I will be in Beirut. So, but there is a lot of to do, and so I'm a doctor, so this is my role.
yeah, we completely understand and we completely respect it. Thank you. Thank you for your presentation today. So yeah, moving
Thank
on
you
to our,
all. And please, can I have by email the presentation of all the participants that maybe we can exchange, and you can provide my address, some few experience,
sure,
comments, or whatever as a
sure,
follow-up?
yeah, it will definitely do
Wonderful.
that.
That wonderful. Thank you very much for understanding. Really, I'm trying my best, but I really definitely wanted at least to speak spontaneously. Thank you very much. So sorry I can't stand long time because there is a cut of the electricity sometimes.
Yeah,
Thank you.
no problem.
Thank you.
Thank you. Thank you for your presentation. Yeah, and your time. Have a great day. So yeah, moving on to our next presentation. So it'll be from Dr. Deepak Kumar from Postgraduate Institute of Medical Education and Research, India. So the topic will be, can inhalation formulation be planned for controlling COVID-19 pandemic? Yeah. So just a So yes, Dr. Deepak, you can just click on the screen option present. So you'll be able to give your screen sharing. Yeah, we can see that.
So hello everyone. My name is Deepak Kumar. I shall talk about can inhalation formulation be planned for controlling COVID-19. The novel coronavirus is responsible for causing COVID-19 illness. It is also named as SARS-CoV-2, that is Severe Acute Respiratory Syndrome Coronavirus 2. It is named as because it shows similarity with SARS-CoV-1, which was known to cause SARS outbreak in 2003 in China. The SARS-CoV-2 causes respiratory illness or infection, which ranges from mild to severe disease condition and causes death. However, there are some people who have the infection but never develop symptoms, means they are asymptomatic. The coronavirus belongs to family Coronaviridae and they have crown-like spike on their surface, as the name suggests. They have envelope. The positive sense means they can be immediately translated by the host cell. They have single-stranded RNA virus, which consists of around 30 kilobase pair. If you talk about the coronavirus, on the basis of the genomic structure, the coronavirus is subdivided into 4 subgroups: the alpha coronavirus, the beta coronavirus, the gamma, and the delta coronavirus. The alpha and beta coronavirus affects mammals, whereas the gamma coronavirus affects avian species. The delta coronavirus affects avian and mammal species both. This picture shows the genetic structure of different coronavirus, that is alpha, beta, gamma, and delta coronaviruses. The coronavirus which affect humans are known as human coronavirus, and the human coronavirus are present in both alpha coronavirus group and beta coronavirus group. In alpha coronavirus group, they are 229E and then 63, whereas in beta coronavirus group they are HKU, OC43, middle is respiratory syndrome coronavirus, severe acute respiratory syndrome coronavirus 1, and severe acute respiratory syndrome coronavirus 2. If we talk about the structure of SARS coronavirus 2, it consists of number of proteins like the S protein, which stands for spike glycoprotein. This protein helps in binding the virus with the host ACE2 receptor, which is present on alveolar cells. The next protein is the M protein, which stands for membrane protein. This protein helps in determining the shape of the virus and stabilizes the N protein and the RNA complex. The N protein is the nucleoprotein. This protein helps in virus replication and it also maintains the helical symmetry of nucleocapsid, which contains the genetic material. The E protein stands for envelope small membrane protein, which helps in production and maturation of the virus. And specifically in case of SARS-CoV-2, another kind of proteins, that is hemagglutinin esterases, are present, that is HE proteins, which play a crucial role in virus entry in the host cell and also release of the virus from the host cell surface to the inside. The outbreak of coronavirus was reported in December 2019 in Wuhan, Hubei province of China, and on 30th January 2020, the WHO declared it an outbreak of public health emergency and international concern. On 11th Feb 2020, it is named as COVID-19 disease, and after 1 month, on 11th March 2020, the WHO characterizes COVID-19 as a pandemic. It is important to note that this is the first coronavirus pandemic. This picture shows the effect of coronavirus infection worldwide, that countries like America, Brazil, India, and Russia are majorly affected by this disease. However, as you can see from this world map, whole the world is getting affected with this coronavirus, and as of now there are around 22 million confirmed cases of coronavirus and around 775,000 deaths were reported to WHO till date. Droplet infection is considered to be a primary mode of transmission. However, in addition to droplet infection, the other mode of transmissions are by contact, airborne, through infected materials, fecal-oral contamination, bloodborne. It can transmit from mother to child, and from human to animal transmission is also observed. To prevent the infection of coronavirus, the guidelines of WHO is to maintain the social distancing and to use mask and sanitizer. If a person comes in contact of a suspected person, then it is advised to be in quarantine for minimum 14 days. To overcome the problem or the coronavirus infection or pandemic, the various healthcare professionals and the biological scientists are working hand in hand to find the cure of this disease. And around 165 different COVID-19 vaccines are being in developing phase. These vaccines are of following types: viral-based vaccines, viral vector-based vaccine, the vaccine which are based on nucleic acid, and the protein-based vaccine. The major pharmaceutical companies which are leading in this vaccine productions are Pfizer, Oxford, AstraZeneca, Moderna, etc. However, on 11th August 2020, the first registered vaccine of COVID-19, that is Sputnik 5, is registered. This Sputnik 5 vaccine was manufactured by Moscow Gamaleya Institute and Defense Ministry of Russia. This vaccine is based upon the DNA of SARS-CoV-2 virus, adenovirus, and it closely resembles a vaccine of Middle East Respiratory Syndrome disease. However, the approval of clinical use of Sputnik 5 came before the completion of a clinical trial. Means currently that clinical trial 3 is going on, still it gets its approval for the clinical use. This raises concern over its safety and effectiveness for the people. In order to treat or prevent the infection of coronavirus, it is important to understand the pathogenesis of coronavirus. So, SARS-CoV-2 virus, when it attaches to the ACE receptor, which is present on the alveolar cells of the host cell, it causes the downregulation of the receptor, that is ACE2. When the ACE2 gets downregulated, this results in altered ratio of ACE to ACE2 ratio, and thus the angiotensin 1 with the help of ACE gets converted into angiotensin 2. When the more angiotensin 2 is formed, this causes pulmonary vasoconstriction, which contributes to acute respiratory distress syndrome, that is ARDS. In addition, on attachment with the receptor, the virus penetrates the cell through endocytosis or membrane fusion. Various proteases like furin, TMPRSS2 helps in priming and activation of the S protein of the virus, which play a crucial role in binding with the host cell, and this causes the release of the virus genome inside the host cell. Then the viral genome enters the nucleus for replication, and then the biosynthesis of virus particle from the viral mRNA take place, and it leads to formation and release of the new virus particle. A large number of production of virus particles causes undue activation of innate immunity, which causes the cytokine storm, and this cytokine storm damages the alveolar cells and produces hypoxic-like condition, which further contributes to acute respiratory distress syndrome. However, various authority believes that the vitamin D status is related to COVID-19 illness. Means various observational studies are there which says that the deficiency of vitamin D were observed in cases of COVID-19 patients. However, they attest or advocate the supplementation of vitamin D to prevent or treat COVID-19 illness. It is important to note that vitamin D exhibits pro-inflammatory cytokines and it promotes anti-inflammatory cytokines. Therefore, it can reduce the effect of cytokine storm and thus decreases the severity of COVID-19 illness. However, we believe that the vitamin D has paradoxical role in COVID-19 illness, and our view we have published, which states that renin, which converts angiotensin into angiotensin 1, the angiotensin 1 then binds with ACE2. However, in case of COVID-19 illness, when ACE2 is downregulated, the angiotensin through the help of ACE gets converted into angiotensin 2. The formation of more angiotensin 2 causes pulmonary vasoconstriction and it causes severe COVID-19 disease. However, when vitamin D is supplemented, it has been evident that the vitamin D suppresses the renin expression and thus the angiotensin conversion to angiotensin 2 via ACE2 will get limited with the help of vitamin D. Moreover, vitamin D also reported to increase the expression of ACE2 and thus it causes increased expression of ACE2. Thus, there is more virus binding sites, and it means more virus binding site, that is ACE2, and thus more virus can bind to the host cell. In this way, by increasing the ACE2 expression, the vitamin D play a paradoxical role. In one way, it increases the expression of ACE2, thus more virus can bind to the receptor. In other way, it decreases the angiotensin 2 by indirectly affecting ACE and thus decreasing the pulmonary vasoconstriction effect. So what we believe that if we use a vitamin D analog that bind with VDR so that it will inhibit the renin expression and decreases the angiotensin 2 formation. In other way, if that analog will bind to ACE2 receptor in the virus binding domain, then it will preoccupy the virus binding site and thus the virus will not get any chance to bind to the ACE2 receptor. So working in this line, we have used tools of computational biology to study the interaction of the vitamin D and its analog with the vitamin D receptor to study the expression of renin and the ACE2 receptor to check whether the chosen ligand or vitamin D interact with virus binding domain or not. Thus, we have downloaded the 3D structures of proteins, that is ACE2 receptor and vitamin D receptor from PDB, and we have also downloaded the 3D structure of the ligands, that is vitamin D analogs. For the initial screening, we have used a docking software, that is Autodock. The Autodock gives value in the form of negative binding energy. Highest is the negative binding energy, better is the interaction of the ligand, means vitamin D or vitamin D analog with the receptor. Through initial screening, we have found that the psilocalcitriol binds with highest negative binding energy with the ACE2 when lysine 31 was chosen as a grid center. So we have selected psilocalcitriol as a screened analog, and because it gives better binding energy with ACE2, and vitamin D to study a comparative analysis of their binding with VDR and ACE2. In case of VDR, we have selected histidine 305 as a grid center for docking, and in case of ACE2, lysine 31, which is a known critical moiety for virus binding, is considered as a grid center for docking. We have performed docking with the two softwares for 6 times. The purpose of using two software is to validate the result. The gold software gives value in the form of fitness score, that is gold score, whereas the Autodock software gives value in the form of binding energy. Then we have analyzed the results and to find out which one out of psilocalcitriol and vitamin D is a better in terms of binding with VDR and ACE2. Then the dot complex obtained via gold and Autodock were further undergo molecular dynamic stimulation to check the stability of the dot complex, means the binding is stable or not over the time. When ACE2 was chosen as a receptor and lysine 31 is chosen as a grid center for binding the ligand vitamin D and psilocalcitriol, we have found that the psilocalcitriol shows more negative binding energy in comparison to vitamin D via Autodock and gives more fitness score in comparison to vitamin D. When vitamin D receptor was chosen as a receptor for psilocalcitriol and vitamin D and histidine 305 was chosen as a grid center, we have observed in this case also the psilocalcitriol binds better than vitamin D to VDR, means vitamin D receptor, and the fitness score is also better for psilocalcitriol with VDR in comparison to vitamin D. This picture shows the dot complex obtained. The first picture shows the complex of vitamin D with ACE2. Figure B shows the complex of cholesterol with ACE2. C shows vitamin D with VDR, and the D shows the dot complex of cholesterol with VDR. Through this dot picture, it is clearly understandable that the hydrogen bonds and the other interactions are there, which play a crucial role on binding of vitamin D or cholesterol with the ACE2 and the VDR. However, the cholesterol binds with VDR and ACE2 better, which can be easily understandable by the fitness score. By the free binding energy. Similarly, the dot complex obtained via gold shows the binding of vitamin D with ACE2 and VDR, and binding of cholesterol with ACE2 and VDR. This picture also shows that number of interactions like hydrogen bond and short contacts are present, which confirm about the binding of the ligand with the receptor. However, in case of cholesterol, the fitness score is better, and thus it gives more stable complex. In order to check the stability of the complex over time, we have done molecular dynamic stimulation run for 10 nanoseconds at 300 Kelvin temperature and 1 bar pressure. We have used the Swiss Perm tool for generating drug topology file, and the CHARM27 force field was used throughout the stimulation run. The purpose of MD stimulation run is just to check the stability of the dot complex obtained via both the docking software of gold and Autodock. The complex solvated in 1.2 nanometer cubic box of water using TIP3T model, and for energy minimization of the complex, step-by descent method was used. The system was equilibrated before MD run using NVT and NVT protocol, which consists of 50,000 steps each. The result of the molecular dynamics dock structure were visualized using PyMol. This picture shows the molecular dynamics stimulation run in terms of potential energy, kinetic energy, radius of gyration, root mean square deviation, and hydrogen bond. And this picture shows the dot complex obtained after MD stimulation run. The MD stimulation run of ACE2 with cholesterol when the dot complex via Autodock is used shows that the potential energy and the kinetic energy was stable throughout the run, means throughout the 10 nanosecond run, and the radius of gyration is getting lower after 6 nanosecond run. The RMSD value becomes stable after 6 nanosecond runs, which indicates the protein is in stable form. Meanwhile, throughout the run, the 1 hydrogen bond were observed to be present for ACE2 and cholesterol interaction. Similar results were obtained for ACE2 and cholesterol when the gold complex was used for MD stimulation results. Means the potential energy and the kinetic energy was stable throughout the run, and the radius of gyration first increases, and then after 6 nanoseconds it starts decreasing and becomes stable. The root mean square deviation becomes stable around 6 nanoseconds, and in this case also the minimum one hydrogen bond was observed throughout the MD stimulation run. Similarly, we have performed the MD stimulation run of VDR with cholesterol when the complex of Autodock was used. In this case also, the kinetic and potential was stable around a fixed value, and the radius of a gyration is almost same, and it decreases after a 6 nanosecond. The root mean square deviation also becomes stable after 6 nanosecond, and in case of VDR with cholesterol, we have observed 1 to 3 hydrogen bonds were there throughout the stimulation run. Similarly, with the gold dot complex, the similar results was observed when MD stimulation was performed. That in this case also, the 1 to 3 hydrogen bonds were observed together. These MD stimulation results and the docking results states confirm that the cholesterol binds VDR and ACE2 better than vitamin D. The vitamin D binding with VDR is known to inhibit renin gene expression. Therefore, if our prediction comes true by experimental validation, then cholesterol will inhibit renin better than vitamin D. It means it will decreases the concentration of angiotensin II and thus decreases the severity of COVID-19 illness. However, it is also observed that the psilocalcitriol occupied the virus binding site better than vitamin D. Therefore, it is expected that the psilocalcitriol will block the virus binding site and will prevent the binding of virus to this virus binding site of ACE2. We attest or advocate the administration of psilocalcitriol via inhalation route because in that way it can give local effect only and it doesn't affect the systemic expression of ACE2. I would like to acknowledge Council of Scientific and Industrial Research, CSIR, New Delhi, India, for providing me fellowship as a grant. This is my working lab, which is placed on first floor of Research Block B, PGMR, Chandigarh, India. This is our team. Thank you.
So yeah, thank you for your presentation, Dr. Deepak Kumar. It was really informative. So do we have any questions for Dr. Deepak Kumar so that he can answer your questions, if any? So yeah, I get there are no questions. So yeah, thank you, Dr. Deepak Kumar, for your time.
Thank you.
So next, we can move on to Dr. Benadella Anwar from University of Abu Bakr, Belkide, Algeria, for his presentation. Dr. Anwar, are you available online right now?
Hello,
Yeah.
I
Hi,
am Dr. Benat. Do you listen to me?
Yeah, we can hear you.
I can begin.
Yeah, you can. You can start with your presentation. Before giving, like, you can just click on the screen button.
Screen button.
Yeah.
Wait. I try.
So yeah, you can just select what you want to share first.
Can you see my slides? No.
No, it's not visible.
Can I begin? I have problem with my PC.
Okay, just a moment, or if you're not able to do it, okay. Just a minute. We'll just have one moment. So actually, once you click the screen option, you'll just see in options to which application you'd like to display.
Stigma late application.
Okay. Let me just help you out with this. I'll be displaying the screen for you. Just a moment. Yeah, can you see the screen right now?
No, I can't see. I can't see it. Can I begin?
Just a minute. Yeah, you can begin. Like I just want to confirm if everyone can just see the screen with the stigma related to HIV in Algeria PowerPoint
Yes, I
presentation.
see it.
It is visible.
Okay, thank you. So yes, Dr. Anwar, you can continue with the presentation.
Thank you. Thank you. I am Dr. Ben Abdullah Anwar from University in Tlemcen, Algeria. I shall speak about stigma related to HIV in Algeria. HIV-related stigma and discrimination refers to prejudice, negative attitudes, and abuse directed at people living with HIV and AIDS. In 35% of countries with available data, over 50% of people report having discriminatory attitudes towards people living with HIV. Finding from 50 countries indicates that 1 in every 8 people living with HIV is being denied health services because of stigma and discrimination. Studies have shown a link between HIV stigma and the refusal of HIV testing, non-disclosure of HIV status to partners. Female sex workers in Algeria is a population that is vulnerable to HIV infection and hard to reach for service providers. There is an institutional stigma in Algeria about FSW because sex workers, female sex workers, are forbidden in Algeria. Donc we begin with this, and we know, we know also that people have stigma about FSW. Our aims is to examine the role of HIV/AIDS-related stigma among FSW plays in HIV testing behavior, the disclosure of positive serostatus, and entry in HIV/AIDS care. We have recruited 40 FSW and interviewed them. Surveys collected information concerning the role of HIV-related stigma plays in HIV testing behavior, the disclosure of positive serostatus, and entry in HIV/AIDS care. Our results. 53% of FSW said they had been denied access to health care. 58% of FSW have been excluded from social activities, and 55% of FSW have tent residency. The behavior of the health workers and the confidential data. Only 55% of health workers divulge the serologic status of FSW. The divulgation of HIV serological status has been done by the FSW to other HIV patients in 35% of cases, to a member of her family in 20% of cases. 20% of FSW did not want to inform their partner or their HIV serologic of their HIV serologic status. 10% of FSW did not want to inform the health workers. 40% of SW have been excluded from familial activities. Only 5% of FSW have knowledge of their rights to medical care, right to health, right to information. In conclusion, the medical environment remains the main area of discrimination in the social life of FSW living with HIV. Programs that favor inclusion of FSW in Algerian healthcare setting are needed. Thank you. I finish. Hello.
I thank you for your presentation.
Thank you. Hello.
Hello.
Can I begin the second presentation?
Yes, you can begin the second presentation.
My second presentation concerns the treatment, the anti-HIV therapy in HIV infected adults being treated for tuberculosis. And we want to make the difference between when we began immediately the treatment and when the treatment is deferred. In introduction, despite wide antiretroviral scale-up during the past 2 decades, resulting in declining new infections and mortality globally, HIV-associated tuberculosis remains as a major public health concern. Tuberculosis is the leading HIV-associated opportunistic infection and the main cause of death globally, and particularly in resource-limited settings. Several challenges exist regarding diagnosis, global implementation of latent tuberculosis treatment, management of active tuberculosis, delivery of optimal patient-centered tuberculosis and HIV prevention and care in high-burden countries. Our aim is to find that starting antiretroviral therapy early, between 2 and 4 weeks after the start of tuberculosis treatment, reduce progression to AIDS and death. Our study was prospective during 36 months. Patients were studied in 2 groups, 89 early antiretroviral treatment and deferred antiretroviral treatments within 8 weeks after the start of TB tuberculosis treatment. And we used Kaplan-Meier curve survival. Concerning the localization of tuberculosis, it was disseminated in 80%. It was pulmonary in 13% and extrapulmonary in 8%. Tuberculosis was peritoneal in 31% and pleural in 23%. Tuberculosis, we observed 2 deaths in the early treatment and 7 deaths in the deferred treatment. This is the biologic disorders observed in these patients. Pancytopenia was the principal, the main hematologic disorder in 30%. In 70%, we show success, immunovirologic success. And in 15%, we observe deaths. We have the survival curves. Donc we show that when we began early the antiretroviral drugs between 2 and 4 weeks, the survival was better than we began the treatment 8 weeks after the anti-tuberculosis drugs. In this figure, we show that the combination efavirenz, lamivir, and zidovudine was better than the other combination. Hypokalemia was a bad prognostic factor. And also, then our study confirms other studies by other researchers who found that starting antiretroviral therapy early, within 4 weeks after the start of TB treatment, reduced progression to AIDS and death. It made also in light bad new prognostic prognostic factors like hypokalemia and hyperleukocytosis. Thank you. I finish.
Okay. Yeah, thank you. Thank you for the presentation. Just a minute. Yeah, so do we have any questions for Dr. Anwar? So if there are any questions, yeah, you can please ask. So yeah, I guess there are no questions. So thank you for your presentation, Dr. Anwar. So here, as the sessions, so for today's, for the day one, the sessions are all completed today. So for tomorrow, we only have the poster presentations, and we really hope you all can meet up tomorrow at 10 a.m. in London time for the poster presentations that will be given tomorrow. So if there's anything, if you're having any query, please do let me know so that I'll be able to answer you.
Thank you. See you later.
Yeah, thank you. Thank you, Dr. Hassan. So I guess there are no queries. So tomorrow at 10 a.m. we do have 5 poster presentations. So we can all meet tomorrow again at 10 a.m. in the morning at London time. So that is all for today. Have a great day ahead.
Thank you.
Thank you.